Hello everyone, how are you all? Thank you so much for joining our today's session. So we're going to do our today's new cluster. So we're starting the pediatric clusters. Now pediatrics has a lot of clusters and it has a lot of cages as well. So it's very important to make sure that you concise your cages into a couple of clusters. Okay, so that's very important. Otherwise, you will feel overwhelmed with pediatrics because I think like even like medicine and pediatrics, these are the main two areas where you have to put maximum effort because there is a lot of cages from medicine and from pediatrics also. Okay, and don't worry on that because we made most of the clusters in the pediatrics, which will cover at least 5-6 cages. So today we are going to do vomiting cluster, and you will see that it covers at least 6 or 7 cages, which are very important for your exam. So let's start. Give me 1 second. I'll just see that those who are in the Facebook, are you guys able to hear me? Today we are going to do. So in those of you are in Facebook, if you are still having any difficulty hearing me or if you have any questions, feel free to write it in the comment box. All right, so let's start the vomiting cluster. As always, when we do a cluster, we start with a differential diagnosis. So what are the differential diagnoses of vomiting in children? If you want to remember in this way that there are some GIT related causes and there are some non-GIT related causes. So GIT related causes are pretty important for the exam. So you have gastroesophageal reflux, pyloric stenosis, duodenal atresia, incarcerated hernia, intussusception, valvular intestinal obstruction, Hirschsprung disease, or sometimes even acute gastroenteritis can come with vomiting. All right, so there is a lot of cases. Now, gastroesophageal reflux is very common in like up to 12 months age group, and usually patients or the children usually have this kind of vomiting, which is not too much projectile, and they usually thrive well, grow well, no problem apart from just vomiting after feeding. Pyloric stenosis, in the other hand, it also comes with vomiting, and it's very common in like initial 3 months, mainly 2 to 8 weeks group, or even more than that, like after 12 months, up to 12 weeks. Now, the difference between gastroesophageal reflux and pyloric stenosis is that pyloric stenosis child will have this projectile vomiting, and most importantly, they will also lose body weight. Then next, your duodenal atresia. It's commonly present you initially just after the birth. Child will start vomiting just within 24 hours of birth, and whenever mother trying to do the breastfeeding, child is vomiting out. So that's duodenal atresia. Incarcerated hernia can come at any age group child. Intussusception mainly present with screaming intermittent, and child will draw up their leg up to the chest as if they are in a severe pain. Then intestinal obstruction, volvulus, they don't have any typical pattern, but most of them will have vomiting. Gastroenteritis, again, child will have vomiting. Child, if it is like a neonate, the child will not be able to tell you that they are having abdominal pain, but in older children, they will have abdominal pain, nausea, vomiting, and also diarrhea. Apart from GIT related causes, non-GI causes are pretty important, and you need to rule that out in every cases of vomiting. especially acute vomiting. Like urinary tract infection can present with vomiting, testicular torsion can present with vomiting, and also any other infection like otitis media, septicemia or meningitis, pneumonia can also come with vomiting. Now, among these cases, what are the exam cases or what are the important cases for your exam? So reflux is important. Pyloric stenosis is very important. Duodenal atresia important, comes in exam. Incarcerated hernia important. Intersusception important. Gastroenteritis important. UTI very, very important. Testicular torsion recent case, very important. So you can see that all are very, very important cases, and most of you might get one of these cases in your exam also. Okay, so vomiting cluster is very important for your exam. Make sure you have a very good idea about the format of this cluster. The good thing is that if you remember one format, you can apply it to all these cases. So let's move on and see how we are going to do that. Now, vomiting history or pediatric history is a little different from the other clusters that we have done. Like we have finished cardiology. Cardiology and pediatrics is way more different, but the thing is always same, that you need to reassure the parents, you need to make sure hemodynamical stability, all these things are always should be there. Now, if it's an online exam, because examiner or invigilator will not answer any of your questions, so you don't need to ask for hemodynamic stability to anyone because they will not answer you. Okay, so this is the first time I'm telling it, because all the time we have been following the previous guidelines, because it was a face-to-face, and examiner or mainly examiner was supposed to answer these questions. Now, examiner doesn't answer any of the questions. Invigilator doesn't answer your question. So there is no way you will ask hemodynamic stability and they will give you anything back. So forget about it. As long as the online exam continues, we will not ask anything from the examiner. All right. So for everyone who are here today, make sure that this is a new thing. Not previously, if you guys are doing my course, you know that always we do this approach. Anyone having anything acute, we ask hemodynamic stability first. But because now in the online exam, they are not answering your questions, so there is no need to ask it. All right. Now, in the history, obviously parents will come and they will be pretty worried about it. So you will start in a very reassuring words. So you will say, hi, this is, let's say the one of the parent is Mary. She's the mother. She came with her 3-year-old child because child has been vomiting since last night. Okay. Now you will start in this way. Hi, Mary. This is Dr. Arshan, one of the doctor here. I got to know from the notes that your child had been vomiting since last night. I'm really sorry to hear that. Please don't worry. Now that you are here, I'll try my best to manage your child's symptom. Your child will be fine. Now, would you please tell me a little bit more about what exactly happened since last night? Okay, so this is how we are going to start here. So in vomiting cluster, or anyone coming with vomiting, that is your history of presenting complaint. So you will start with your HOPC first. So start with the vomiting patient. Any time there is discharge from anywhere in the body, we follow the approach CCVO, so color, consistency, volume, and order, which means you are going to ask about what is the color of the vomitus, what was the content, and volume, that is it a large or a small, and order, is it a foul, smelly or not. So always, like anyone having bleeding, anyone having any discharge from anywhere, vomiting, everything, usually we will follow this CCVO approach. So start in this way. So can you please tell me more about what exactly happened since last night? So open-ended question always. role player will answer some of your questions. Now, if they don't, then you need to find out these answers. So since when it started, now if you already know that it started since yesterday night or last night, you don't need to ask it again. Okay, many of the candidates follow the format and they just ask questions which already been answered by the role player. So don't do that. But you need to find out these questions answers. So if any of these things is not been answered by the role player, then you ask it specifically, like since when it started, how many episodes so far, is it for the first time your child having this vomiting, and then come to the CCVO. So what is the color of the vomiting? It's very important to know the color, because anything coming up in the stomach or like proximal to the duodenum or intestine, it should be whitish in color. When intestinal contents comes out from your vomiting, it should be greenish in color. So color will give you a very good idea that from where this vomiting coming up. Is it from the intestine, or is it from duodenum, or is it from stomach? So what is the color of the vomiting? Have you noticed any blood in it? What is the content of the vomitus? Like, was it like most of the patient will say that, or most of the mother will say it was all breast milk. Okay, so we need to know the content of the vomitus. Was it a small or large in amount? So that's for your volume. And then ask about, is it foul smelly or not? So CCVO is your important thing. So color, any blood, consistency, volume, and odor. Then next you ask, is it forceful or projectile? Now, forceful projectile vomiting is a characteristic of pyloric stenosis. So it's very, very important question. Any relationship of this vomiting with feeding? How long after feeding does he vomit? So if this question answer is yes, like any any relationship of the vomiting with the feeding, yes, then ask how long after feeding does he vomit? Does or is he hungry, or does you can say that is he hungry just after the feeding? Patient with pyloric stenosis, just after feeding, they will start vomiting and they will be hungry and they will start crying because they are hungry. Okay, so this three question is very important. Is it forceful or projectile? Any relationship of the vomiting with feeding? If yes, then how long after feeding does he vomit? And is he hungry just after the feeding? Clear? Any question? Sound was not clear on Facebook. Okay. I will answer your question, guys. Let's just finish this vomiting format, then I will answer your questions. Okay. Now, after HOPC, our format is always same. After HOPC, we ask associated symptoms. So what is the associated symptoms with vomiting? Someone vomiting, usually they can have abdominal pain, abdominal distension. These are mainly we want to find out. Sometimes we also want to find out any sign of intestinal obstruction. Now, in this case, if you don't want to ask associated symptoms, you can start differential diagnosis that will also fulfill all our differentials. If like any distension of the tummy, we can ask it in the intestinal obstruction question as well. So forget about associated symptoms in here because this will be covered in your differential as well. So whatever works out for you, you can keep it. But I would suggest keep it as a differential. Associated symptoms in this case will not be very needed, like not very important. Now, what are the differential diagnoses we are going to ask? Start with GIT related causes followed by infection related causes. So for intestinal obstruction, you can ask how about his bowel habit? When was the last time he passed his stool? any history of diarrhea or constipation. So bowel habit and waterworks will be your first thing to ask. Now you don't ask about urinary habit or how is his micturition. You always use non-medical words. All right. So start with the intestinal obstruction questions. How about his bowel habit? When was the last time he passed his stool? Any history of diarrhea or constipation? Next is urinary tract infection. Because bowel habit waterworks, it comes immediately in our mind. So keep it as it is. How about his waterworks? Have you noticed any change in number of wet nappies? Any change in color or smell of the urine? Does he cry while passing urine? Now, in this urinary habit or in waterworks, two things you will know. One is UTI, another is that if this child dehydrated or not. Children who are dehydrated, they will have decreased number of wet nappies. So that's why you ask any change in number of wet nappies. Now, children with UTI, they will cry out when they pass urine. So does he cry while passing urine? And also they can have some change in color or smell of the urine. So any change in color or smell of the urine. Once you finish with bowel habit and waterworks, then one by one you go into the other differentials. So for intersusception, you can ask, does he draw up his legs while crying? Does he turn pale while crying? Okay, so intersusception child usually have this sudden onset of screaming that comes and goes. When it comes as an episode, child draw up his legs up to the chest as if he is in severe pain. And also they can turn pale while they are crying. So that's for your intersusception. After that, go to the other infection related causes. So have you noticed any fever, any rash? For otitis media, any discharge from ears, any pulling of ears. For pneumonia, any cough, shortness of breath. Okay, so that's your main differential diagnosis. If you come to the differential, now you will find out gastroesophageal reflux, there is nothing to ask. Your vomiting question is all that you need to ask. Pyloric stenosis, vomiting questions are all that you need to ask. Duodenal atresia, uncommon in child who is not like newborn. If it's a newborn, vomiting question is all that you need to ask. For incarcerated hernia, for that, you need to ask, have you noticed any lump or bump anywhere in the tummy, especially in the groin? So that's incarcerated hernia. For intersusception, we are already asking a question. Intestinal obstruction, we have bowel habit question. Gastroenteritis will be covered in bowel habit. UTI, we are asking. Testicular torsion. Now, it's very, very hard to ask question in these in testicular torsion cases, but you can always find it out in the physical examination. Or even you can ask to the mother, have you noticed any redness in the genitalia or private area? Otitis media, septicemia, and pneumonia, we are asking. All right. So most of the differentials we are asking just by following these vomiting questions and then this differential diagnosis. So start with the vomiting question, ask bowel habit, waterworks, ask about intersusception, pneumonia, otitis media, and meningitis or septicemia. Once you have done with the differentials, the next format is always same for all other pediatric questions, which means we ask well baby questions, we ask binds, we ask TMAC, past medical history, and family history. Now let me discuss a little bit about all these things. For well baby question, we usually ask four things. What are those four things? One, you ask about mental status of the child. So is the child active, alert, or drowsy? That's mental status. Second, You ask, is he feeding or sleeping well? Okay, so feeding and sleeping. Third is waterworks. Four is bowel habit. Now you already asked waterworks and bowel habit, so you don't need to ask it again. So only thing you can ask, is the child active, alert, or drowsy? Is he feeding and sleeping well? The next one is binds. Now binds has a lot of things to ask, but depending on your time and how you are doing it with the history, you can always cut it out. Now, in binds, there is birth history, I for immunization, N for nutrition, D for development of the child, N is for, you can say, social or support. Now, in this case, in vomiting cluster, you need to ask about the birth history. So ask about how was the birth of the baby? Is he a term or preterm baby? Okay, any complication during pregnancy, delivery, or after delivery? Ask about was it a normal vaginal delivery or cesarean section? Sometimes duodenal atresia can be associated with Down syndrome. If you think this is a Down syndrome case, you can ask, please excuse me for asking it, but can I know what was your age at the time of the birth of the baby? Because if mother is like 35 or 40-year-old, chances of having a Down syndrome baby is very high. So at that time, you can ask it, but not always. Mainly in birth history, you want to know about how was the birth of the baby, term or preterm baby, normal or cesarean section. Was there any complication during pregnancy, during delivery, or after delivery? There are a lot of other questions also. It's not relevant to this cluster. When we will be doing pediatric respiratory system, we will discuss it in detail. Okay. For immunization, just one question, is he immunologically up to date? If they don't understand you, then you can ask, is his vaccinations up to date? Nutrition, you don't need to ask it, forget about it. Development is important. Do you think he is growing and developing well? Why it's important? It can help you to rule out pyloric stenosis, because pyloric stenosis child will not grow well, they will have loss of body weight. So it's a very, very important question, development and growing history. Social history is not very important in this case. So birth history, immunization, and development is all that you need to ask here. TMAC. TMAC is not important mostly in this case, but if you think this is a infection related cause, then you need to ask TMAC. TMAC is only important if you suspect infection. So TMAC means T for travel. So any recent travel history. Is he on any medication? Any history of any allergies? Any contact with someone having similar complaint? So contact history, we usually in children, we ask contact history that does he go to the child care? Anyone in the child care having similar symptom? Anyone in the home having similar symptoms? Like if it's a gastro case, it can be like a child care outbreak. So that's why in this case, you can ask about contact history. So that's your TMAC, travel history, medication, allergies, and contact history. There is a huge benefit of these mnemonics because it will help you to remember most of the important things. Even if you want to forget, if you remember this mnemonic, you will not forget it. And lastly, finish with any other past medical history, any family history. So we always finish our pediatric history in this way. Well baby binds, TMAC if there is a chance of infection, past medical history, and family history. Okay, clear guys? Any questions so far? So just to recapitulate, in vomiting cluster, our format will be starting with the vomiting questions, followed by differential diagnosis, starting with the bowel habit, water works, ruling out other DD like intersusception, incarcerated hernia, and then other infection like meningitis, otitis media, pneumonia, followed by well baby question, binds, TMAC, past medical history, family history. Now you might be thinking that will I be able to finish it in time, because it seems a lot of questions. Yes, it seems a lot of questions. That's why you need to prioritize your questions in the exam. So you don't need to ask all these questions to every patient, just a relevant one. If you're running out of time, forget about binds, forget about TMAC. You just need to finish it. Okay, so you need to make sure that you complete your task. That's the important part. Any question in the format, guys? If not, then we will start our cases in here, starting with the urinary tract infection. So Dr. Sadaf, you asked, so sir, if any patient is not stable, it's mentioned in role player card. Now, one of the thing is here, as per I understand, that all the vitals will be given in your stem, that they will be, it will be written in this way that vitals are stable most of the time. Okay, and maybe when you will be given a PEFE card, then they will write the vitals. If you see that this patient is having a shock or hemodynamically unstable, you will manage that patient right away. That means immediately when you see the PEFE, you will just read out the PEFE, then you have to go to the management part, right? Then you will manage the patient at that time. You don't need to ask hemodynamically stable or not initially, because nowadays in online exam they don't answer your questions. Yes, now just wait for this month exam. All right, in March exam there was no PEFE, it was all on the card. Now it can be changed, so don't just delete it from your brain, keep it as it is. If we see that it's been going on for the whole time, then yes, then we will not practice PEFE anymore. All right, Dr. Hafsa, have you got your answer also? Now, Dr. Anika, very good question. So if from PEFE we get to know that patient is unstable, we will manage in the beginning. Now, the question is, PEFE card usually given after you finish your history. It's not like in your STEM, you will get the PEFE. Now, in the STEM, if they say that patient is unstable, patient's blood pressure is 80/50, then you should manage at that time. Okay, but when you get the PEFE card from the invigilator, then in the PEFE card, let's say patient is unstable. You don't need to just manage at that time, because in the PEFE card, you will take at like just a 30-second or just 1 minute, and then you will go for managing this patient, right? That time you manage the patient when you explain it to the patient. But if there is no management given in the PEFE or in the task, then when you get the PEFE card and if the patient is unstable, manage at that time. At least say that you want to send the patient to the resuscitation cubicle and you want to do that. Okay. So it depends on when you get to know that patient is unstable. All right. Now, so let's move on. Urinary tract infection. Very, very important case for your exam. So a mother came with 9-month-old female baby with fever and vomiting for the last 2 days. You are a GP. Your task is to take a history, physical examination finding from examiner. Now, this will be probably a PFE card, so don't bother. Diagnosis and further management. Now, if it's a fever and vomiting cluster, so you should remember that someone having fever and vomiting, your first thing to remember is that this patient can have any infection in the body. So what are the infection that you're looking for, which can cause vomiting and fever, right? So you will first start your question with vomiting. You will start your question with fever. Okay, so let's start in this way. So in the history, you will reassure the mother, then start in this way. Can you please tell me more about it? Which one came first, fever or vomiting? If fever comes first, start with the fever question. So can you tell me since when have you found out that your child having fever, or since when fever started? Is it continuous or on and off? Any chills or shivering? Did you measure the temperature? Have you given any medication like Panadol? If yes, then did Panadol help? Okay, so these are the fever question. After that, you go to the vomiting question, same vomiting question, just like we did now. Once you have done with your H2PC, fever and vomiting, then you come to your differentials. Now, in this case, your differential should be started with the fever related question first, which means you are not going to ask about bowel habit. You are not going to ask about intussusception initially in this case. Okay, so keep it in your mind that anytime you get fever in your questions, we always ask head to toe infection related source question. So starting with the head, where it can have infection, it can be meningitis, right? It can be a viral upper respiratory tract infection, which can be like a runny nose, can be having sore throat, right? Patient can have sneezing. So all these are upper respiratory tract infection signs. Then it can be otitis media. After you have done with your face or upper respiratory tract system, go down to the chest. So pneumonia. Then go to the abdomen. In the abdomen, you can have two things, gastroenteritis and UTI, right? So that's mainly your fever-related source question in children. So start with the differential diagnosis. So for meningitis, only thing that you will ask, any rash anywhere in the body. Otitis media, any discharge from the ear, any pulling of ear. Any runny nose, any coughing, any sneezing, okay, or any flu-like illness. For pneumonia, any cough, shortness of breath. For acute gastroenteritis, how is his bowel habit? So all the bowel habit question you will ask here. Any diarrhea or constipation. For UTI, water work question. Okay, so once you are done with your infection related source question, then you can ask other GIT related vomiting question. Then you can ask these questions like incarcerated hernia question, intussusception questions. For pyloric stenosis or gastroesophageal reflux, we don't have any specific question, only this will be covered in vomiting question. Once you are done with that, then same like previously, well baby question, binds, past medical history and family history. Now, in this case, in past medical history, specifically ask about any past history of urinary tract infection or kidney disease. Because children having one-time UTI, they are prone to develop recurrent UTI sometimes. So it's very important to know that is it the first time UTI or recurrent UTI? And is there any family history of kidney disease? So that's your question in here. In urinary tract infection case or any fever vomiting case, you will follow the same format. Fever and vomiting question first, then ask about all infection related causes, then GIT related causes, well baby binds, past medical and family history. Now, in the PEFE, what actually we are looking for, that's important to know also. Now, because we used there were it was a PFE was a very important task in exam previously. That means you were supposed to ask question from the examiner to find out the physical examination findings. Now that it's given in the card, you don't need to remember this thing, but you just remember that what you are looking for in the card. Okay, now still we will just go through the PEFE because we don't know that AMC can introduce it anytime because it's not a hard thing to do. Examiner can give findings anytime they want. Okay. So because it's just a initial exam, we are not deleting this task yet. In PEFE, you ask to the examiner or invigilator if it is given at the moment. So you'll start with the general appearance. So dear examiner, I would like to know the general appearance of my patient. Is he active, alert, or drowsy? Any dysmorphic feature of Down syndrome? Ask about pickled. Mainly in pickled in here, important thing that you want to understand is there any sign of dehydration? Palloricterus you can ask. It's not very important in this case, but you can ask palloricterus or is there any sign of dehydration? Sign of dehydration, you cannot miss it because it will be a key step. Okay, so make sure that you don't forget asking about dehydration. A child having vomiting, it's a very, very important thing to know that if the child is dehydrated or not. Sometimes you also ask for any rash for meningitis mainly. And is there any skin pigmentation? That's for congenital adrenal hyperplasia. So in general appearance, we are looking for a lot of things. Okay, so after you have done with the general appearance, then go to the vitals. In the vitals, you already know that we are looking for blood pressure, pulse, temperature, respiratory rate, and saturation. Most important in this case is to know about the temperature, right? Because this patient having fever. In pediatrics, asking about growth chart is mandatory. You cannot forget asking growth chart if there is a PEFE in your task. Okay, so how you ask it, is there any growth chart available? After you have done with the growth chart, then you start your examination. In this case, you will start initially with the ENT examination, then you will move downwards. So you will say, dear examiner, I would like to do a head-to-toe physical examination, but starting with the ear, nose, and throat examination. In the ear, what you're looking for, is there any ear discharge, any tympanic membrane changes? In the nose, any nasal discharge, any nasal mucosal changes? In throat, what you're looking for any tonsillar enlargement, any tonsillar exudates. Okay, so this is ear, nose, and throat examination. After that, because meningitis is one of your important differential, you should always ask about neck stiffness. So is there any neck stiffness positive? Then you do this other systemic examination, mainly focus on abdomen because it's a vomiting case. Your main system will be abdomen. So on focused abdominal examination, on inspection, is there any visible distension, any visible peristalsis or mass? On palpation, any palpable mass, any tenderness? On auscultation, is the bowel sound audible or not? So that's your inspection, palpation, and auscultation. In every abdominal examination in children, you have to check their hernial orifice and genitalia. So with the consent of the parent, I would like to check hernial orifice, genitalia, and also paranal inspection. Paranal inspection is not very important in these vomiting cases. It's more important in someone having abdominal pain or having diarrhea. But hernial orifice is very important because it could be a case of incarcerated hernia. Genitalia is important because it could be a case of torsion. Okay, so don't forget about checking for hernia and genitalia. After you have done your abdominal exam, then just very quickly say, I would like to finish with all other system, including respiratory system, cardiovascular, and central nervous system. Is there any office test available like urine dipstick? Mainly, you need to look for the urine dipstick here. What you're looking for in the dipstick, you're looking for leukocyte, nitrite, or any RBC. Okay, so that's your main physical examination from examiner in case of vomiting cases. So if I recapitulate, then in PFE, you are starting with the general appearance. Is he active, alert, or drowsy? Any dysmorphic feature of Down syndrome? Making sure you ask about dehydration, rash, and skin pigmentation. Ask the vitals and growth chart. Then do the ENT exam, neck stiffness, focused abdominal exam, and lastly finish with office test with urine dipstick. It's very important to find out the urine dipstick because it will help you to diagnose this case. Okay, so once you are finished with the PEFE, then your next task will be diagnosis and differentials or diagnosis and further management. So how we can manage UTI? So you'll say, Mary, most likely your child is having a condition called urinary tract infection. Do you know what it is? Most of them know already, but still you can say it's an infection of the urinary tract caused by a bug. Please let me draw a picture for your better understanding. You can very quickly draw the kidney, ureter, and bladder. Okay, and you can say that, well, this is the kidney, this is the ureter, bladder, and urethra. In your child case, most likely any component of this urinary tract has got infected with a bug. Now, as this urinary tract is very close to the back passages, bugs can easily enter into the urinary tract and then causing infection and inflammation, which manifest as fever, vomiting with a painful, smelly urination in children. Okay, so explain what is UTI, explain how it happens, because in female, urinary tract is very close to the back passage. Bugs can easily crawl into the urinary tract from the back passage, causing infection and inflammation. And it presents as fever, vomiting with painful, smelly urination, just like your child is having. Now, as your child is still 9 months old and is considered to be a part of the vulnerable group of patients, I would like to send your child to the hospital via ambulance. Any child less than 12 months having fever, vomiting, there is a possibility of septicemia. So this child will go to the hospital. Okay. So as your child is still 9 months old and considered to be a part of the vulnerable group of patients, I would like to send your child to the hospital via ambulance. In the hospital, she will be seen by a child specialist for further evaluation and management. So what they are going to do in the hospital, that's you are going to talk about. As the initial urinary dipstick is just a screening test for the infection, most likely they will do another test to confirm the diagnosis, which we call suprapubic aspiration. In suprapubic aspiration, a small needle will be inserted just below her belly button, and then a sample of urine will be collected and sent for culture to confirm the bug and sensitivity. Please don't get scared. It will be totally pain-free and will be done by a very experienced doctor. So if it's a less than 12-month-old, in the management, you have to talk about suprapubic aspiration. Okay. So you can say, are you understanding me, Mary? Is there any questions? No, doctor. Well, now once once they send the urine for culture, specialist might also start your child with antibiotic to fight the infection, and also they can give your child paracetamol to address her fever. Sometimes the specialist might also decide to do further evaluation by doing an ultrasound of her urinary system to exclude any structural abnormality causing this infection. In some children who has recurrent urinary tract infection, specialist may also do another test called micturating cystourethrogram, where a special dye is inserted into the urinary tract to look for any structural abnormality. But as your child just had this infection for the first time, most likely specialist will not go for this investigation this time. But again, this will be decided by your specialist. So why we're talking about it? Because this is a part of management. You're not saying that this child will going to have all this. Most likely initial or first time UTI will not have any ultrasound or MCUG, but you are just giving this information in case it happens recurrently. They'll have to do this ultrasound and MCUG. Okay, so this is a part of management. Please don't get worried. Most of the children with UTI make a good recovery and have no future problem. Your child will be taken care of by the hospital. And also, once your child get discharged from the hospital, please come back to me. I will review her regularly. Always try to wipe her from front to back. Give ample amount of fluid to make sure she doesn't get dehydrated. Anytime after the discharge, your child having fever, vomiting, change in color of her urine, or please come back to me again. I will give you reading materials which you can read on the way to your hospital. Do you have any questions? Okay, so this is how you manage. Now remember one thing, in this case, management might not come, only differential can come. So in that case, you will just give your diagnosis as UTI and all other differential, just like we used to say DD. You all know how to do that because I have described how to give differentials in case it is a task. Okay, so remember one thing, in management, your key steps will be explain what is UTI and how it happens. Sending the child to the hospital is must. Talk about suprapubic aspiration, talk about antibiotics. These are must. Now, some of the examiner like you to talk about ultrasound and MCUG. So keep it if you get some time. If you don't get time, don't worry, it will not fail you. And lastly, reassure the mother and finish with 4R. Okay, so normally fever, vomiting, usual time period is 6 months is very vulnerable, Dr. Madiha. 6 months is very vulnerable. Now, even 9-month-old having fever, vomiting, it's always a good approach to send to the hospital because who knows, it could be a septicemia also. Okay. Any question, guys? If already in ED, then you will obviously admit the patient. Yes, if it is less than a year old, usually we will send the child to the hospital or admit the child to the hospital. In older than 1 year old, if child is vitally stable, not dehydrated, and not vomiting everything she is taking, you can send the child to the home by giving antibiotics. Okay, but it depends on the general status of the child. In case child becomes more than a year, if the child is totally fine, like systemically well, child is not vomiting too much and not dehydrated, then you can send the child with oral antibiotics. But most of the child with UTI initially will be very sick and they usually get admitted. All right. Next. Next cluster is your gastroesophageal reflux. Now remember one thing, there is a term called gastroesophageal reflux disease also. So always make sure you understand the difference between these two. One is gastroesophageal reflux, which is a physiological response in a newborn child or children below 1 year old. The physiological response means that whenever you feed the child usually like vomits or throw out some of the food. But child grow up well, everything is fine, apart from just vomiting after feeding. But some of the time that can be complicated with gastroesophageal reflux disease. And that's not physiological, that's pathological. So never use the diagnosis gastroesophageal reflux disease in case child is totally fine, growing well, developing well. All right. So let's go in detail of this term so that you don't get it confused in the exam. Many candidates just fail because of that. So what is gastroesophageal reflux? Is the passage of gastric contents into the esophagus. So all of you know what is reflux, right? It's a physiological process that occurs several times in a day in a healthy newborn or healthy child. Majority of the child usually gets better within 12 months of age. Now, when you will call it as a gastroesophageal reflux disease, if a child has this reflux or vomiting, along with any of these features, it is called as GORD. So, pronounced irritability with arcing of the back, refusal to feeding, and in later on, child not gaining weight properly or losing weight. If child has vomiting with blood, having chronic cough, wheezing associated with reflux, and having history of apnea, which means they are stop breathing for a few seconds. Any of these present, then we call it as a gastroesophageal reflux disease. So what could be the positive things in the history in gastroesophageal reflux? So child will have this vomiting after feeding. The color of the vomiting will be whitish in color. Sometimes it can be even projectile. Don't just diagnose it as a pyloric stenosis if it is projectile. The main thing is that as long as child is gaining weight, it's not pyloric stenosis. All the examination will be normal, no other sign and symptom of gastroesophageal reflux disease. History will be totally same like how we are doing. PEFE will be same also. Only thing that you will add in the history that you will ask some of the symptoms of gastroesophageal reflux disease, which means that you will ask the parents that have you noticed any arcing of the back. When you ask about the well baby question, then you will find out that if the child is feeding well or not. Also, when you ask about growth and development, then you will find about the weight loss. When you ask about vomiting, you also ask, is there any blood in vomiting? So you are ruling out hematemesis. You can ask these two questions. So have you noticed any cough or any musical sound from the chest? That's wheezing. You can ask, have you noticed any time that your child stopped breathing for a few seconds? That's apnea. Okay, so only add these symptoms with your history. So management. In the management in here, most likely your child is having a condition called gastroesophageal reflux. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So you can just draw a picture of esophagus and a stomach very quickly, and you can show it to the patient just by holding your paper in front of the camera. And then you can say, see that this is the food pipe and this is the stomach. The lower end of the food pipe connects with the stomach. In children less than 12 months old, this lower end doesn't develop properly. And that's the reason sometimes milk in the stomach flows back in his mouth and then he vomits. It's a very common condition where the baby vomits after each feeding, but otherwise he thrive well and grow well. This condition gradually improves with time, especially after introduction of solids, and majority of the child gets better within 1 year of age. Please don't get stressed. Now, it could be due to other reason as well, like it could be pyloric stenosis, but your child is growing and developing well. It could be any infection in the body. So just give all of the differentials. If management is a task, then you have to say some of the management of gastroesophageal reflux. It's just some of the modification of the lifestyle. What are those? So as part of the management, there is no specific treatment that you need to have at the moment, but I will recommend you to give him a small, frequent feeding. Decrease the duration of feeding along with the time in between. Also, you can thicken the food with some thickeners called Gaviscon. You can also elevate the head of the cot by 10 to 20 degrees. After each feeding, please do not put your baby immediately to sleep. Carry him for a while and put him in cot with head elevated. We highly recommend breast milk because it is best for your baby. If this maneuvers doesn't help in few weeks, I will refer your child to a gut specialist who might start some medication, especially some acid suppression therapy. But most of the child usually gets better just by following these methods. Please don't worry, as long as your child is growing well, developing well, feeding well, there is nothing to be worried of. I will regularly review him and give you reading materials. In case you see that your child is having pronounced irritability with arcing of the back, is not gaining weight properly or refusing to feed, having cough, or you notice that he stopped breathing for a few seconds, please come back to me immediately. So this is actually the red flag of gastroesophageal reflux disease that you have given. Also, you already said that you are going to review him regularly. You're going to give the reading materials. No need to refer to any specialist now. Okay, so that's mainly your gastroesophageal reflux disease. Dr. Diana, what's PEFE? PEFE is physical examination from examiner, which means you need to ask physical examination finding from the examiner. Don't worry on that. You are in a good luck because in AMC clinical, as is say online now, most likely you will not need to ask physical examination finding from examiner. They will provide you with a card. It's a very, very good thing. Remember, because PFE is a headache. Now, if it's given in the card, you have a lot of time also. Now, remember one thing, previously, because PFE was there, management was not a very common task. Now that PFE comes in the card, management will be a common task. So you need to learn management now. Okay. All right, let's take a 10-minute break and then we will do all other cases related to vomiting cluster. The next task will be, next one we will start is pyloric stenosis. Okay, so 10-minute break. All right, guys, so let's start again. Dr. Madiha, if history is leading to reflux, do we need to refer for ultrasound to rule out? No, no need. It's not mandatory to do that unless you think that it's a pyloric stenosis. You don't need to refer because most of the time, pyloric stenosis is a clinical diagnosis. So let's start with the pyloric stenosis. You are a HMO in ED, 6 weeks old baby with a vomiting brought by his mother. Your task is to start with a history, PAFE, explain the diagnosis and management. What could be the positive findings in history? So most of the time, as I said, pyloric stenosis is common in 2 to 6 weeks of age. It's very rare to happen after 12 weeks. Child comes with vomiting and it's always non-bilious. So it should not be a green vomiting. Okay. So it's a non-bilious vomiting, progressively more forceful and projectile. Child often get hungry afterwards and there will be weight loss or inadequate weight gain. So this is very important. So like a 4 weeks child having projectile vomiting, not gaining weight properly, non-bilious vomiting, you should always think about pyloric stenosis. On physical examination, you should always look for dehydration because most of the child will be dehydrated here. Some of the other signs that you can find, one in inspection on abdominal exam, you can get gastric peristalsis, which usually like there will be a wave of muscle contraction starting from the left upper quadrant of the abdomen going towards the right lower quadrant. So that's a gastric peristalsis, you can get it. On palpation, you can feel a pyloric mass, mostly in the right upper quadrant. Sometimes it also known as olive-shaped mass. If you do a feeding test, which means that you ask the mom to breastfeed and you want to see that how the vomiting comes, you will find out child starts vomiting just after feeding and it's a kind of projectile vomiting. So that's called positive feeding test. So these are the signs that you are looking for: dehydration, gastric peristalsis, and a pyloric mass. Okay, so your history and physical examination is totally same, just like the cluster that we have done. Management is a different. So say that most likely your child is suffering from a condition called pyloric stenosis. Do you know what it is? No, doctor. Well, let me draw a picture. So draw the same picture of stomach and duodenum. Like you can draw like this. Right? So you can say that, well, the milk goes from the mouth through a tube-like structure called food pipe to the stomach. From the stomach, milk then goes to the small gut. In pyloric stenosis, the lower end of the stomach, called pylorus, get narrowed. And as a result of that, the milk or whatever the child drinks cannot pass down to the small gut and child starts vomiting it out. And due to vomiting, he is losing fluid from his body, getting dehydrated, and not gaining adequate body weight. Mary, I'm really sorry to say, but this is an emergency condition and an operation is needed to fix the problem. Please don't get scared. I'm going to send your child to the hospital via ambulance right now. I will also arrange for a pediatric emergency retrieval team and arrange transfer for your child to the hospital as soon as possible. In the hospital, he will be seen by a child specialist for further management. Diagnosis is usually clinical, but they might do an ultrasound to confirm. They will also do frequent blood tests to check his salt and acid-base levels. In case he gets dehydrated, They will also start him on IV fluids. Also, I would advise you not to feed him from now onwards because this can make things worse. If your child keeps vomiting after you have stopped feeding, they might also insert a tiny plastic tube through his nose down to the stomach to remove any contents from the stomach. Once your child gets stable, most likely an operation will be needed to fix the problem. Your child will be able to start eating and drinking within 6 hours of the operation. Once the problem has been repaired by surgery, Mary, it is unusual for this condition to come back again. I do understand that you are not expecting any of this, but I want to assure you that your child going to be fine, and we will do our best to manage your child. If you want me to call anyone, your friend, your partner, anyone, I would be happy to do so. But I want you to know that we will take care of your baby and your child going to be fine. Okay. So this is how you will reassure the mother. It's very important in this case because mother will not have any idea that this child is going to have a surgery now, right? So you have to be very, very reassuring in this case. The main points that you cannot forget is you need to talk about what is pyloric stenosis and why this is emergency, because due to vomiting, your child is losing fluid, child is losing salt and minerals, child is not gaining body weight. And if these things continues, it can be quite life-threatening as well. Okay, so that's why this is an emergency condition. You need to make sure you send the child to the hospital. And then what will happen in the hospital? They can do an ultrasound, talk about IV fluids, talk about NG tube, and talk about operation. Reassurance is must in this case. You don't need to say how surgery will be done because that will be discussed in detail by the surgeon. Clear, guys? Any question? Feeding test. The feeding test is positive in case of pyloric stenosis because what you will do in this case, you will ask the mom to breastfeed. And once the mom start breastfeeding, usually it's just soon after breastfeeding, child will start vomiting. And that will be quite projectile. If you see that's happening, then you know that this is pyloric stenosis most likely. Clear? Next is intussusception, another important case for your exam. Yes, you can order peristalsis, like sometimes when the child breastfeed, the gastric peristalsis can become more evident. So you can also look for gastric peristalsis as well. For intussusception, you are a HMO in ED, 5-month-old boy with multiple episodes of screaming for the last 6 hours. Has vomited twice in the last 3 hours. Your task is history, PEFE, explain the mother, the condition, and further management. So as you can see, intussusception very commonly comes with episodic screaming, which starts suddenly, and child can also have vomiting and bloody diarrhea. So in this case, again, reassurance is very important. Your HOPC is screaming. So you will start with the presenting complaint. So can you please tell me more about these screaming episodes? Since when it started? Anything particular happened just before this episode start? So sometimes it can be anything like maybe child swallowed something. We don't know. So that's why it's important to know that anything particular happened before this episode start. Is this continuous or episodic? How many episodes so far? Does he draw up leg to the chest while crying? And does he turn pale while crying? These two are very specific questions for intersusception. So anyone is screaming acutely, we always ask these two questions. Once you are done with that, you go for your vomiting question, right? Because your HOPC will be one is child is having multiple episodes of screaming and another is vomiting. So you started with the screaming questions followed by vomiting question. Then you start your differential diagnosis. In this case, same other differentials. So intestinal obstruction, intersusception. For intersusception, in here you can ask, have you noticed any loose stool or any red colored stool? For incarcerated hernia, any lump or bump in the groin, and then followed by all the infection related causes. Okay, so DD is same like all the vomiting clusters we have done, it's the same differentials. Finish with well baby binds past medical and family history. In this case, PEFE will be same format, but in the physical examination, when you do the focused abdominal exam, some of the important finding you should ask for or look for. What are those? One of them, on inspection, you can get abdominal distension because it's a kind of obstruction. So on palpation, you can get a sausage-shaped mass. Okay, so on palpation, you're looking for any mass, especially any sausage-shaped mass. Also look for emptiness in the right iliac fossa. Sometimes in children, tenderness is not possible to find out, but you can ask for it. But mainly you are looking for any mass and emptiness in the right iliac fossa. These are positive in intersusception. Auscultation, you are asking for bowel sound. Sometimes you can get alternating high-pitched bowel sound with absent bowel sound. And always, you will always finish with this hernial orifice, perianal inspection. Now, remember one thing, in intersusception, it's very, very important to look in the paranal area, looking for any red currant jelly-like stool. It's very, very commonly given in the exam, not very common finding because it's a late sign for intersusception. But in the exam, you should always look for any red currant jelly-like stool in this case. Okay. Now we already discussed the positive points. No need to ask it again. Physical examination we discussed. Mainly, we are looking for sausage-shaped mass in the right upper quadrant. We are looking for any emptiness in the right iliac fossa. We are asking for distended abdomen. We are looking for any sign of dehydration. Okay. Then you come to the explanation. So you say that most likely, based on the history and physical examination, your child is having a condition called intersusception. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. So you'll just, like, you can ask very quickly, like one gut going into another, right? Something like that. So intersusception is a condition in which there will be a sliding of one part of the gut into the other. And because of the sliding, the bowel can get blocked or obstructed, and that ultimately leads to severe pain and vomiting. It is an emergency condition, and that's why we need to admit your child and then involve the child specialist. In the meantime, please do not give any food and drink to your child. I will put an IV line and start him on IV fluids. The specialist might order ultrasound and X-ray of the tummy to rule out any obstruction. Once the diagnosis is confirmed, treatment is given by the specialist, a radiologist, and a pediatric surgeon. Most likely, they will go for air enema, which is passing a small tube at the back passes through which air will be passed. And with the pressure of the air, most of the time, this blocked gut will be untwisted again. Please don't worry. Throughout the procedure, your child will be monitored by the specialist and he will be in sleep. Unfortunately, if this procedure doesn't become effective, then surgery might be needed as well. Please don't worry. Now that you are here, we will give our best management to make him as comfortable as possible. Your child will be fine, and give some reassuring word as well in here. Now, in this case, it's same like pyloric stenosis. This is an emergency situation. So you have to say that in this case, what's happening is that it's an intersusception. It's a sliding of one part of the gut into the other. And because of the sliding, bowel can get blocked or obstructed. Now, if bowel keeps blocked or obstructed like this for a long time, this part of the gut will not get enough blood, and ultimately the gut can get perforated, and this could be a life-threatening complication. So that's why it's very important that we admit your child and involve the child specialist. Once you give some frightening things to a parent, make sure you sandwich it to some reassuring word. Okay. Now, obviously, you need to say to the parents that why this is urgent, but just after saying those things, give some reassuring sentence like, I understand this looks really scary to you, but I'm not trying to scare you, Mary. I want you to know that your child is in good hand, and with appropriate management, your child is going to be fine. Okay, so always reassure. Reassurance is must. In any of the acute surgical emergency, management is pretty same. So you admit the child, you involve the senior and the child specialist. In the meantime, you ask the mother not to give any food or drink, and you put an IV line. Sometimes we do ultrasound to rule out or confirm the diagnosis, and then further management can be surgery. In intersusception, usually we do air enema. So in this way, we will manage. All the surgical emergencies are pretty much same. Clear, guys? Any question? No. So as I say, Dr. Hafsa, nowadays this is a new thing, because I know that you guys were you know that we always ask you to say the hemodynamic stability, because you can't ask hemodynamic stability to the examiner. Examiner is supposed to just stay on the site. They are not supposed to answer any of your question, not even the invigilator. Invigilator, the job is just to guide you throughout the exam. They are not supposed to give you any more information. That's only thing you will get is from the PEFE card or from the STEM, nothing else. So it's a little confusing, I know, but we need to adapt with the new system. All right. Cool, guys. Any question? Is this too much for you? We have a lot of other cases. No, that's a good question, Dr. Tasnova. If it is associated with obstruction or perforation, then obviously we have to go for surgery. Because if it is perforated and you give air enema, you are just pushing all the intestinal contents into the peritoneum. Okay, good. The next, incarcerated hernia. Now, this case is pretty important and pretty confusing as well. Why? Because most of you don't even think about incarcerated hernia coming in the exam. And that's the reason they usually play with you. And most of the time, even parents are not aware that their child is having a hernia. Okay. So maybe in the history, whenever you, if you even ask that, have you noticed any lump or bump in the groin? Parents can say no, because they haven't noticed. Might be. So that's why PEFE will be a very, very important thing in this case. Okay. Now, a 5-month-old baby coming to your GP clinic with his mother because of sudden onset of intermittent screaming with a few episodes of vomiting. Older brother has got a recent onset of gastroenteritis. Task is history, physical examination finding from examiner, diagnosis and management. So now if you look at here, this is also sudden onset of screaming and having vomiting. You can easily get confused with intussusception in this case as well. So you cannot be biased in your exam. You have to be very open. Anything can come in the exam. So you have to trust your gut. The cases we are doing is for your understanding that this is how cases comes in the exam. But in exam, any case can come. You have to be always open. Another case comes in this way that 3 months old, irritable baby for 3 weeks. Today, mother noticed a lump on the inguinal area. So this one is actually just a reducible inguinal hernia case. And this one is incarcerated hernia case. Anything can come. Now, in this case, history will be totally same. You will be very lucky if you get from the parents that they have noticed a lump in the groin. Even if you don't get it, don't get stressed. In the PEFE, you will get it. So in the PEFE, everything will be same, but mainly when you go for this inguinal orifice, then most of the time, examiner will show you one of the picture of a inguinal hernia, which is red in color, and like it will seem like obstructed or irreducible. So you will see that there is a picture of a inguinal hernia, which is quite red. Okay. Now, next question is to find out that if this is reducible or irreducible, is it tender to touch? And you can also ask for cough impulse. Now, if it's a 5-month-old, asking a 5-month-old to give a cough is totally silly. So it depends on the age of the child. Okay. But if it's an online exam and PFE card is provided, so most likely they will provide you a picture, and also they will give you the finding that there is a firm irreducible inguinoscrotal swelling in the right or left side. If it is not, if it's a PFE, then you have to specifically ask it to the examiner or invigilator. So if you get it like there is an inguinoscrotal swelling and that's tender to touch and irreducible, then this is incarcerated hernia. So from history and examination, most likely your child is having a condition called incarcerated hernia. Do you know what it is? No, doctor. Well, let me draw a picture for your better understanding. A hernia is a protrusion of part of gut or fatty material through a weakness or opening in your tummy wall. So you can just draw like this, like just show it. It's very unusual that you will let them understand what is hernia by drawing picture, but you can just draw like this. You can say a hernia is a protrusion of part of the gut or a fatty material through a weakness or opening in the tummy wall. It is usually seen as a bulge under the skin in the groin area. Now, Mary, in a simple hernia, the material that comes out, they are usually able to move freely in and out of the defect, which we call reducible hernia. Now, if the part of the bowel becomes trapped and cannot return to the tummy, then it is at risk of having its blood supply cut off. In that case, you will not be able to reduce the contents back to the tummy. Your child start having pain in that area. It will become swollen and red and tender. And even sometimes as the bowel is obstructed here, your child starts vomiting. And this we call as irreducible or incarcerated hernia. Are you with me so far, Mary? Yes, doctor. Mary, because this part of the gut is not getting enough blood supply, this is an emergency condition that we need to arrange for surgery immediately. Please don't get scared. Your child is in the best possible hands. So right now we need to admit your child. I will involve my senior and also the child specialist for further management. As of now, please do not feed him or let him drink anything. We will put an IV line and start him on IV fluids. Most likely, a specialist will go for surgery to put the blocked gut back inside, and then just they can also do some strengthening of the weaker part of the tummy. The method of surgery and also the risk of the surgery will be discussed detailed by the surgeon with you. Please don't get scared. We will do our best to manage your baby's condition. We have a very good team of doctors here. I know that you have not been expecting any of this when you came here, but please remember that you did the you did a good job bringing your child here, and we can manage your child's symptoms. In case you want me to call anyone, I would be happy to do so. Do you have any questions? If it's in the ED setting, you don't need to give 4 hours, okay? Cool. Any question for this incarcerated hernia? Now, good question, Dr. Hafsa. Even if it's not incarcerated, the child should have at least a elective surgery. Children with inguinal hernia should be having surgery as soon as possible. So even if it's a reducible hernia, then you will say that, well, now it's reducible hernia, but anytime the gut content can get blocked, and then that part of the gut will not get enough blood supply, and then we'll call it as the incarcerated hernia. And then your child will be in most severe complication, and there will be high risk of like having this having the part of the gut become non-viable or perforated, and that will be an emergency surgery at that time. So we can prevent all this complication by doing an elective surgery, making sure we put the gut back to its normal position and we strengthen the weaker part of the tummy. In that way, we can prevent this complication to happen. Okay, so children should have the surgery. If it's a reducible hernia, then it will be an elective operation. Any question, guys? Okay, next. Duodenal atresia. This is very important case for the exam. So case can be like this. You are working in a small country hospital as HMO. You have been called to talk to a 27-year-old mom, Janil, who gave birth to a baby boy 24 hours ago. She started breastfeeding, but he has vomited several times, some greenish fluid, and hasn't passed meconium yet. The neonatal checkup did not reveal any pathological finding, and anus was present, which means that it's not an imperforate anus. Okay, and an abdominal X-ray is provided. Take a brief history, explain the X-ray finding to the mother, discuss the most likely diagnosis and management with the mother. Very important. Now, looking at the question, you should understand this might be a case of duodenal atresia. So, 27-year-old mom gave birth to a baby boy 24 hours ago, right? So immediately after birth, child start having this greenish vomiting. Because it's a duodenal atresia, it's coming from intestine, it will be greenish in color. Now, if you look at the X-ray, you will get this double bubble sign. See the double bubble? That's specific for duodenal atresia. So your task is to take history and then explain X-ray finding to the examiner, to the patient. Now, in this case, again, the same thing, you will reassure the mom, you will congratulate the mom because just she had the baby, and then start same question. So vomiting questions, start all other associated question, rule out most of the differentials. Okay, the question will be more or less same. Your explanation is very important in here. So explain the X-ray. So you will say that, Janil, this is the X-ray of your baby's lower chest and tummy. Okay, so this is the X-ray of your baby's lower chest and the tummy. In the X-ray, some shadows are whitish and some are blackish. The whitish are mainly which has bone, and blackish is mainly which contains air. Now, the lower part of the chest, in here, you can see these are the lungs, and lungs contains air. That's why they are blackish. In between this blackish shadow, you can see this whitish line. This is his rib cage. And in the middle, this is the vertebra or backbone. Now come to the tummy. If you look at the tummy, you can see these two blackish shadow here. These are air shadow, which is normally should not be in his X-ray. In a normal child, it should not have any blackish shadow like this. And when we see this, two gas shadow, we call it as a double bubble sign. And this double bubble sign is specific for a particular condition in newborn known as duodenal atresia. Are you with me so far? Yes, doctor, I can't understand what is duodenal atresia. Well, don't worry, Janil. Let me draw a picture for your better understanding. So you draw like this. Right? So you can say that duodenal atresia means there is an absence of part of the small bowel known as duodenum. Now, when you give breast milk to your baby, breast milk enters from the mouth into the food pipe, goes to the stomach, and then it was supposed to go to the gut through the first part of the gut known as duodenum. In your child case, this duodenum is absent or not formed normally. And that's the reason whatever you are giving to your child, it cannot pass down to the gut, and your child is vomiting everything that you are giving. I'm really sorry, Janil, but please don't worry. Your child is in safe hand. It's not an uncommon condition. Okay. And I want you to know that this condition needs immediate management, which is I need to refer your child to a tertiary hospital as soon as possible. I will arrange an emergency transport system for the child, which is the pediatric emergency retrieval team. Your child needs to be in the hospital at this time, and he will be assessed by a child specialist for possible surgery. In the meantime, please do not feed your child. We will start with the IV fluid, and if he keeps on vomiting, we might need to insert an NG tube to decompress the tummy. Please understand that outcome of the surgery is very good, and sooner we manage, the better it is. After the surgery, there is very low risk of any complication, but the surgery and its risk will be discussed in detail by the specialist. They can also arrange a lactational nurse for you to teach you how to express and store breast milk for the moment. Now, in this case, it's a duodenal atresia, and it's very common in Down syndrome children. So in your history, remember what I said in the birth history, please ask that what was your age during the birth of this baby? And always ask, before asking age, ask gently, like, please excuse me for asking it general, but can I please know that what was your age when you had your baby? And did you have your Down syndrome screening? Okay, so then after that, you explain what is duodenal atresia, and because child is vomiting everything, so he's losing fluid, he's getting dehydrated, so it's an emergency situation. You need to send the child to the hospital. In the hospital, child will be admitted, will be seen by a pediatrician and a pediatric surgeon as well. And in the meantime, they will insert IV line, start with the IV fluid, and sometimes they can also insert NG tube if the child keeps on vomiting. Surgery is must in this case, and always reassure that outcome is very good. We don't need to say in this way because we are sending the child to the hospital. Obviously, we are not going to do the surgery. But it's a general fact that outcome is usually good for this sort of surgery. And if the child needs to be alive, this child needs to have the surgery. There is no other way around. All right. So this comes to an end to our vomiting cluster. Now, if you see that we discuss a lot of cases today just by this vomiting cluster. Now, I know like maybe one or two cases that is still missing. That case I will discuss in our vomiting cluster role play session. We are going to have a role play session on the vomiting cluster in the next class. So if anything we miss, we'll cover in that class. So when was your next class? Let me have a look. So on 7th of April, right? This 7th of April will be your last session for free 2 week session. So I hope that you guys are enjoying the 2 week session. Now, many of you has already been admitted in our course. So if anyone is still hasn't been admitted, but you still want to admit, please make sure that you talk with us, you send an email to us or message to our messenger that you want to join, because you should start processing now, just to make sure you get continuity with the class. Those who are in the Facebook, do you guys have any question? No? Okay. So yes, Dr. Visna, we haven't made any new batch Facebook group yet, but the 2 weeks free sessions, this group will be your main group after 7th of April. Okay, so we will delete all other candidates and we'll just keep the students who wants to join. Okay. All right, guys. So thank you so much. We'll see you on 7th of April. We will do the role play on the vomiting cluster. Yes, Dr. Visna, what's your question? Yes, you will get certificate of completion. Yep, obviously. All of our students are going to get the certificate of completion of 5 months course. It's not CPD. We are actually trying to get this accreditation, but it's not CPD accredited. But you can write that in your CV that you did a bridging course. All right. So thank you, everyone. Have a good night. Bye. We'll see you on 7th April.